Good morning, good afternoon, and everyone. I'm Benedict Walter from the Network for Improving Quality of Care for Maternal, Newborn, and Child Health. Thank you for joining this first webinar in a series on lessons from improving quality of care during COVID-19. This is a series organized by the Network for Improving Quality of Care for MNCH and the World Health Organization. We started this series because what we saw over the past few months is a lot of discussion and reflection about the struggle to maintain access to services and to maintain quality of care in these services for maternal, newborn, and child health. But what we also saw, talking to our colleagues, is really pocket of adaptation, adaptability, and improvement that we wanted to share. We have this team of quality improvers that are analyzing problems, going through cycle of testing solution and learning as they go. So this series is really dedicated to their learning and their lessons. Today's lesson, which is the first one, is on the importance of remote coaching and learning during the crisis. And we have a story from Nigeria, where the RICOM 3 project has been using an array of digital resources to support coaching and learning, both with communities and with health workers. RICOM 3 stands for Reducing the Indirect Cause of Maternal Morbidity and Mortality, and it's implemented by a consortium of JPIGO, MDoc Healthcare, and HSDF, and supported by MSD for Mothers. So the way today is going to go, we have two parts in this webinar. The first part are two presentations. You have two presenters presenting RICOM 3. The first being Dr. Ugo Okoli, who is the project director for RICOM 3, and also the deputy country director for JPIGO in Nigeria. She would then be followed by the presentation by Dr. Kendra Njoku, who is the quality lead and head of programs and MDoc Healthcare. And then we really want to hear from you in the second part. This is not a lecture, it's very much a conversation, or at least we hope so. So please type your question in the chat box at the bottom right corner of your screen during the presentation. My colleagues and I will curate them, and then we leave 25 minutes in this webinar for the speakers to answer them. Type your question and we'll make sure they'll be answered. We're also recording these sessions, so we will be sending you a link to the recording as well as all the presentation by the end of the week. I am now giving the floor to our first speaker today, Dr. Okoli from JPIGO. Dr. Okoli, please.
Thank you, Benedict. Let me wait till Kendra shares the presentation.
You should have it up now, Dr. Okoli.
Okay, can you put it on a presentation mode? Thank you. Yes. So thank you, Benedict, and welcome everybody that actually have joined us this morning. We really thank the Quality of Care Network and the World Health Organization for giving us this opportunity to present our work on reducing the indirect causes of maternal morbidity and mortality in Nigeria. This work is being implemented by a consortium of partners, JPIGO, MDoc, Health Strategy Delivery Foundation, and the work is funded by MSD for Mothers. If we move on to the next slide. So our presentation outline today will be to give you a brief overview of RICOM 3. RICOM 3 is an acronym for Reducing the Indirect Causes of Maternal Morbidity and Mortality. And then we'll touch on the high levels of findings from the phase 1 assessment, and also touch on the women-centered quality of care model that we are using and our quality of care approach. And we devote more time in phase 3 implementation of remote learning and coaching for self-care, especially during the peak of the COVID-19 pandemic in Nigeria. We'll end by the learning, presenting the learning from the digital health components of the RICOM 3 project. Next slide. Okay, so just to give you a bit of background and rationale for this project, we know that globally, that and also in Nigeria, that we are all undergoing an obstetric transition, where we already know that currently a lot of pregnant women die mostly from severe bleeding. But however, the proportion of maternal deaths due to indirect causes is actually increasing, and in Nigeria is mostly due to infectious causes such as malaria, but also pre-existing conditions such as high blood pressure, diabetes, obesity, anemia, mental health, HIV. Some of these risk factors can actually lead to preeclampsia and eclampsia, and also can lead to cardiovascular disease complication in women of reproductive age. If we move on to the next slide. So what are we doing then? So our goal in the RICOM 3 project is to apply the quality of care model to improve prevention and early detection and management of these indirect causes I've mentioned along the pregnancy continuum in health facilities. We are focusing on 4 clinical areas, looking at high blood pressure screening and management, both gestational and chronic, the same thing with diabetes, chronic and gestational, obesity, and anemia amongst women of reproductive age. So we are working in 2 states in Nigeria, Lagos and the Federal Capital Territory, and also 4 local governments in these 2 states. We are implementing in 20 health facilities, 10 in each state, and the health facilities cut across public and private hospitals. So what is the implementation overview? So we started in November 2018, and we have implemented in 3 phases. Phase 1 was the assessment of prevalence of women who might have these risk factors. We did actually a survey of 639 women and point of care testing for about 400 women. We also assess facility readiness to actually provide quality of care for the gaps that we identified. And then for phase 2, we gathered stakeholders together, the State Ministry of Health, Federal Ministry of Health, and then also professional associations and women to design a women-centered quality of care model. And in phase 3, which started in October 2019, we are implementing in these 20 facilities in both Lagos State and the FCT. So just to give you some information on high-level findings from the survey that we did, and then also the point of care testing that we did in phase 1. Women actually had limited awareness of the risk factors of these indirect causes, and we had a high proportion of them having high blood pressure, obesity, anemia, and of less extent diabetes. And it was a relatively young population that we surveyed and did point of care tests for. And only a small portion of these women that had the diagnosis actually knew or were aware of their status. The facility assessment also highlighted many quality of care gaps, notably is the low provider knowledge and confidence in managing these indirect causes, and of course, weak information system. We also interviewed stakeholders, which included the policymakers, women, professional associations, and so on. And they all highlighted the many opportunities we had to strengthen the health systems and also facility services and community interventions to achieve our objective in Lagos and FCT. Next slide.
It's a bit frozen.
Okay. Okay, just one more slide before that. So gathering all these stakeholders together, we use the findings and the gaps that we found in the assessment in phase 1 to design a women-centered quality of care model with key components of education and awareness raising amongst the community and women, early detection and screening, management of complications, and coordinated referrals. And this, we suggested, could be implemented across the community and at various touch points at the health facilities, such as the ANC, PNC, delivery, outpatient unit, and family planning unit as well. But the slide in front of you is showing our key implementation approach, which actually aligns with the WHO MNH quality of care framework implementation approach. The leadership, action, learning, accountability, and also involving the community. So for us at the leadership level, we have very huge support and commitment by the Federal Ministry of Health, the NCD division, the Reproductive Health Division, which is under the Family Health Division, are all supporting this project. At the state level, the Ministry of Health, and also at the facility level, the OICs and the QI teams. For action, we implemented on-site capacity building to refresh the knowledge of healthcare workers, but we also augmented it with the ECHO virtual sessions, which Dr. Kendra will go into more details about. And then we established quality improvement teams in the 20 facilities. The teams actually use the gaps and improvement to set improvement aims, and also developed quality of care measures, which they are actually following through. We also have a virtual support of women on a complete health digital platform to improve self-care, and we will give more details into as we go along this presentation. One of the things we also did as part of action was to also do a peer-to-peer learning events between the ministry and the health facilities to share success and achievements, accountability following quality of care measures, and using data for decision making. And finally, community. A month ago, we assessed the experience of a sample of these women using ANC facilities, and the findings were sent to the QI teams to use it to keep improving the quality of care. So I'll now hand over to my colleague, Dr. Kendra, who will take us through more details, and especially activities during the the peak of the COVID-19 pandemic in Nigeria. Over to you, Kendra.
Thank you, Dr. Okoli. And so in talking more, in doing a double click into the digital approach that we used for the RICOM 3 project, it was aimed on two things, right? And then the first one was that we would provide support, virtual guidance to 1,200 women of reproductive age on self-care and lifestyle modifications through the MDoc Complete Health platform. This was to drive the demand side of quality of care. We're also intentional about linking this to facility-based care by making sure that the time when the women do go to the health facility, they receive good quality of care. And so we augmented in-person trainings with the virtual teleecho sessions that held on a monthly basis. Our core belief was that a digital set of nudges would build the women's self-efficacy so that they would seek self-management as well as adopt lifestyle modifications towards healthier and happier lives. And so this really took a multimodal and integrated approach to make sure that the women improve their self-efficacy and to make sure that the quality of care delivered by the health workers also improved. Working with stakeholders within both the federal and state level of the government agencies, we've sensitized facilities and the women of reproductive age. The women were then onboarded onto the Complete Health platform, which is a digital platform that allows them, work towards healthier, happier lives. So let me tell you what the Complete Health platform, process was like. So once onboarded by our community ambassadors who were within the designated facilities and also within the communities, we, the woman once onboarded was introduced to her personal health coach, as well as a supportive multidisciplinary team that was made up of specialist coaches such as the nutritionist, the fitness instructor, the mental health coach to provide mental health support. Based on her risk stratification at onboarding, because she would answer a couple of onboarding questions of whether she had what chronic diseases she had, what were her health goals. She was added to relevant support groups with her peers. But the chat functionality of the Complete Health platform also allowed her to engage through chat directly with her coaches. And so over chat, whether privately or whether on the Complete Health, on the peer support groups, she was able to receive health education messages daily on important topics that related both to pregnancy and general health care, as well as care for the chronic disease if she did have one. She was also able to ask her questions and receive answers, as well as learn from the answers to the questions that other women had posed. If she was termed high risk,
We seem to have lost Kendra. Let's give her a few seconds. And if she cannot resume talking, Dr. Okoli will be able to take over from here.
The health coach, the principal health coach, would call her. Hello?
Kendra, you're breaking off. Can you start your last sentence again, please?
Oh, okay. So I was saying that, can you hear me properly now, Benny?
Yes, I can maybe switch off your video at this point.
Okay.
Thank you.
Okay. And so if the woman, if she was termed high risk, then the coach will call her within 24 hours. In addition to all the other, benefits of complete health, she will receive that coaching call where the coach would walk her on a personalized action plan. And so what complete health afforded the women was that it became their personal health record, where, they could take this record to the hospital at any points in their routine or urgent or emergent care, so that the healthcare worker could look into the woman's progress during the 99% of the time that the woman was not at the facility. We worked with healthcare workers being very intentional to stay within boundaries, complementing their services, but not replacing their services, and making sure that we referred the women with nudges for routine and as well as for emergency needs. We augmented, like I said, the capacity building of the health workers by introducing monthly teleecho sessions. And during the COVID pandemic, we introduced the teleecho sessions for the mothers as well, which we termed as virtual antenatal care, postnatal care classes that held every Saturday evening. All this were geared towards having a healthy and happy mother and baby at the end of the pregnancy period. And so by 30th of September 2020, we had exceeded the target of 1,200 women of reproductive age, just because of the interest of the women. They were referring their friends and their family members, as well as the collaboration with the healthcare workers who were eager to get their women on board. And so as of 30th of September, we had 6,473 women onboarded. We noticed that despite the fact that 97% of them had secondary school certificate and above, and 79% of them had smartphones, we noticed that this does not translate into having a high level of health literacy or digital literacy. And so we had to spend significant effort in building both health literacy and digital literacy. For those women who did not have the smartphone, they just had the basic phone, we supported them through SMS messages as well as voice calls. The average age of the women enrolled was 30 years. Now, we found the women to be deeply engaged, with coaches providing self-care and clinical touch points for both the women and their babies. On the screen, you see an example of some of the questions the women would ask. They would ask questions related to breastfeeding or care of the cord or signs of labor, as well as trying to understand what their health indices meant. So we saw a shift from not knowing their health indices to knowing their health indices, but more importantly, seeking to understand what it meant. As of 30th of September, we had sent over 81,000 messages to the women. We'd had close to 9 million interactions with them in different ways, either through, the fitness coach sending them exercise videos, the nutritionist showing them a demo of not just what to eat, but how to make it the food in a nutritious way, to personalized action plans, to phone calls. We had called close to 6,000, made close to 6,000 calls to over 3,000 women. it's important to know that 30% of these calls were after work hours, so between 5 p.m. in the evening till 8 a.m. in the morning, as well as over weekends. So this was a 24/7 service being provided. The average call lasted for a little bit over 9 minutes, and the range of calls was between 1 call to 20 calls per woman, depending on what her need or her risk assessment was. And so to launch successful teleecho programs, it's really critical to involve several stakeholders. And we had to determine together with the stakeholders, the what, the who, the when, and the how. And so the what was to align with the goal of the RICOM3 project, which was to reduce indirect causes of maternal mortality and morbidity, focusing on 4 chronic diseases, which were hypertension, diabetes, obesity, and anemia. We looked at the gaps within the system, both at the baseline and routinely throughout the program. And because of that, we found that we had to change some topics based, to more pertinent topics based on what we were seeing from the field. Who did we hold this echo sessions for, this tele-education sessions for? We had 2 types of tele-echo sessions. One was for the healthcare workers from within and also outside our selected spoke facilities. Then we also had one for the pregnant or nursing mothers and their caregivers, which we launched during the COVID, which we launched in March during the COVID pandemic. At the peak of the COVID pandemic. Now, to know what day was suitable and to improve attendance, we polled the participants to find out what day of the week worked for them and what time of the day. For the mothers, Saturdays was good. After the help of all the house chores and relaxing, they were ready to learn in the evening at 4 p.m. Now, it was we're very intentional about building digital literacy. As of when we started our teleecho sessions last year, Zoom was not on everybody's lips. Not everybody had the efficacy to use the Zoom platform. And so we had to, in person and virtually, coach facility and healthcare workers on how to join these webinars and do the same thing for mothers when we started with the mothers. We provided data stipends to the core 20 health facilities we worked with. We selected seasoned subject matter experts. So because we were providing reproductive care and we were providing these, in relation to chronic diseases, it was very important to have, a couple of obstetricians, high risk pregnancy consultants, the cardiologists, the endocrinologists, pharmacists, people, specialties that were related to providing the needed care. It was not the regular webinar where someone just came and taught didactic sessions. We used case presentations from the facilities themselves to discuss the practical management and look for what has worked well and what could we improve during these sessions. And that really drove learning. We used quiz questions and polls to track our knowledge gain. What we found was that when the topic areas resonated with the interests and trends, that the healthcare workers and the women were interested and very keen on increasing their knowledge. We had to switch up topics to COVID-related topics, delivering care in the context of COVID when COVID happened. Many of these facilities at that time had not seen or knowingly seen a diagnosed case of COVID. And so we had to, prep the care workers for that. The mothers were also really anxious about what COVID meant for them in terms of seeking care while pregnant and also delivering during the COVID pandemic. So topics during that time were geared to a start. We've had over the last 11 months, 13 echo sessions for healthcare workers, teaching 2,590 attendees on the call. For the mothers, over 7 months, we started this on a weekly basis, and then it became 2 weekly. We had 12 sessions for the mothers and their caregivers. So we had husbands attend the calls as well across 7 months, and approximately 1,200 people had attended. So the use of the case studies really created a platform for sharing and learning. And we were very happy to see both an increase in knowledge and change in practice. We started out with 20 core facilities assigned to the RICOM3 project, but quickly expanded, having over 70 health facilities attending our monthly echo sessions. They were majorly primary and secondary healthcare facilities. 81% of these participants were from Nigeria, were based in Nigeria, while we saw the rest of the attendants coming from across Africa as well as outside Africa. Now, in typical teleecho sessions globally, there's an average knowledge gain of 5% for nurses and 14% for doctors. So we were really excited to see a 15% increase in knowledge for the healthcare workers that attended, as well as a 12% increase for the moms and their caregivers. But outside the knowledge gain that was tracked through the polls, if you look at the slide on the screen, you will see the picture of one of the teleecho sessions, and you see how active the chat room was, where there was lots of learning. You know, either healthcare workers or mothers will ask questions, and the subject matter experts on the call will, you know, answer. And this, we saw, you know, we got testimonies of change in practice. We had facilities changing their management based on recommendations during the call from the subject matter experts. In the picture there is a 20-year-old twin pregnancy, a lady with twin pregnancy who had preeclampsia. And, you know, 3 lives were literally saved by this woman's case being presented on the teleecho session. Now, COVID happened, and we know what role COVID played, you know, in disrupting routine services. One key lesson we learned was that, you know, we had a lot of an increase in undiagnosed hypertension. Now, the impact of COVID was, you know, as we know, a decline in access, you know, to services, essential services such as antenatal care or and postnatal care. The women were confused about where to seek care. And so we had to work with our partners, with the facilities to, you know, find out who was open, where was open, as well as use a NaviHealth platform, which is basically an online directory to navigate women to where they could receive care. The women, there was also fear and anxiety around contracting COVID-19. And all this just increased the pressure that was that the MDoc health coaches had to, you know, really be there for the women when they, you know, in the way that the women needed the support. We saw a lot undetected changes in health conditions. So one of the things that the coaches did were to keep nudging the women to go to the health facilities, to neighborhood pharmacies, since they couldn't access the health facilities, to keep going to neighborhood pharmacies to check their BPs and come on the Complete Health platform and track it. And we saw that 35% of the women who had normal BP readings when they enrolled on the program had gone on to have high BP, you know, post onboarding. The graph on the side is a real graph of one of the women who started out in February with a BP of 134.77 millimeter mercury, and across the months, you know, receiving a nudge from the coach, had gone to check her BP and you know, linking her to the facility. The diagnosis of preeclampsia was made. We're very happy that we're able to nudge her to care and that she got her, you know, care, and she delivered a baby who is doing well. Working with the facilities was also important. And so during the COVID-19 pandemic, you know, at the peak of it, because it's not over yet, as we all know, it was important to identify, you know, what relevant services were being offered, map out what relevant services were being offered so we knew where to send women to. And this was done through telephone calls and through the quality improvement WhatsApp groups. Support was also provided in, you know, was also provided through telephone on reorganizing the ANC services. We ensured that there was social distancing, that the hand washing services were ready, and that, the high-risk women were prioritized. Leaflets and infographics were provided, relevant leaflets and infographics were provided from, sources such as WHO and the National CDC, to make sure that everybody was equipped with the right knowledge and we were busting the myths that were out there. There were weekly calls and mentoring of the healthcare workers, as well as, that discussion on their WhatsApp platforms about following each echo session about what change ideas they could derive from their learnings and implement at their facilities. A lot of change ideas were shared and generated using this process. And so our COVID response was really multifaceted. We had to prioritize high-risk pregnancies, providing more touch points for them, provided virtual ANC, PNC, and newborn care touch points, not replacing facility care, but answering basic questions that helped women to remain healthy. We provided mental health support because there was a lot of anxiety and depression going around. We increased the frequency of teleecho sessions for healthcare workers, focusing on COVID-related topics. We introduced the teleecho sessions for women. We provided PPE, mama delivery kits to some select hospitals and women, launched a COVID support group, COVID and pregnancy support group. And like I said, distributed infographics and materials virtually, as well as provided patient navigation services. Just a few results. We surveyed 119 women following, our provision of virtual support to them. And we saw that all could attest to improving their self-efficacy as well as health and digital literacy. At the follow-up survey, 96% of women said they could better manage their health and chronic disease. This was a 34% increase from baseline. They scored high scores on being able to properly latch their babies during breastfeeding, being able to follow an exercise routine, and being able to add less salt to their food. I know that a lot of people will consider 6.5 over 10 as not a high score, but coming from a baseline of little or no exercise, we consider 6.5 over 10 to really be an improvement. But all this improvement over digital platforms would not have been possible if they did not improve their digital literacy, their ability to use their phones. And we saw that 73% of them said they were now able to use their phones, more comfortable using their phones for health-related reasons, than before they enrolled with MDoc. We saw very high scores. We now wanted to test the actual knowledge of, self-care and care of chronic diseases, of knowing the risk factors. And so we asked them a couple of questions. 80% of them now knew that 140 over 90, having 140 over 90 as your BP was not normal. 93% of them could say the benefits of exercising during pregnancy. 85% of them knew that obesity and being overweight was a risk factor to getting diabetes and hypertension in pregnancy, as well as 85% of them who could now define what diabetes mellitus was, that it was having excess blood sugar in their bloodstream. In wrapping up, this is just a picture of a 28-year-old woman who was enrolled on the MDoc platform. She had pregnancy-induced hypertension. Her coach supported her through behavioral changes, such as routinely tracking her BP and, nudging her to go to the hospital with any high BP. She was able to uptake the minimal forms of exercise, so introduced walking into her routine, as well as reduce her salt. When she was scared of induction of labor, her coach played a really key advocacy role, talking with her husband about the need to comply with the guidance from the healthcare workers. And we're happy to say that she did go for the induction of labor. She delivered her baby and has continued to receive postnatal and newborn care support. So in summarizing our learnings, we had so much learnings using this digital approach. And one was that, it is really important to improve that is really, really important that in improving self-efficacy, that we need to provide guidance on not just self-care, but on clinical care as well. And that because of how integrated the community is with the daily living in a continent such as Africa, that there's a very important role of advocacy with husbands, with mother-in-laws, with the community in general, in providing that support to women of reproductive age to access and get referred to health providers when needed. We were very, very intentional about integrating the self-care support that they received on the digital platform with the facility-based care, because we knew that you could not do it in silos if you wanted to achieve your desired short-term and long-term health goals. Artificial intelligence played a key role because we were learning. It was repeated PDSAs happening. We had to be agile in the way that we reacted to what we were hearing in the field, and keep incorporating and upgrading with artificial intelligence and machine learning to make sure that we were stratifying and teletriaging these women correctly, and we were taking the burden off the coach to really make it as more digital and automated as possible. We knew this, but we saw this demonstrated, the use of behavioral science, that using reward systems, we held things like exercise challenges, different challenges that nudged the women to adopt, these lifestyle modifications that we wanted to give them. And we gave them, gifts that they treasured. So either it was a BP machine or an activity tracker wristwatch or baby clothes, just to nudge them towards right behavior. And the last but not the least is that, COVID, especially in the face of COVID, just having that existing platform enabled us to, as a project, as an organization, really be agile in responding to the needs of the women that we support. Thank you very much.
Thank you very much, both Dr. Okoli and Dr. Njoku. A lot happened in the chat while you were presenting, and I've seen that Dr. Okoli was very busy answering as many questions as she already could. I will now submit some of the questions to you, and you have different type of question. One is about some clarification about the data that you presented on the project, another type of question around the technology, the access to the technology. Then you have a stream of question about urban settings versus what this would mean for rural women. Then some question on COVID and some very specific on the implementation of the project. I'll start about the question about data, and Dr. Okoli answered many of those already. I think that what was pending was why you targeted women from 18 years old until 49 and not younger women? Are there not loss of pregnancy in younger women?
Okay.
Okay, go ahead, Dr. Okoli.
Okay, and Kendra, you can add to this as well.
Okay,
so
sure.
When we did the assessment, because we are working with individuals in the community, we needed to get an independent review board approval for the survey and assessment. And the independent review board actually suggested that we start with 18 years to 49, because if it's less than 18 years, there are issues around child rights and all those sort of issues. Dr. Kendra, if you want to also add to that response. So okay. That's why it was 18 to 49. Yeah.
Yeah. So we started out rightly, like Dr. Okoli said, 18. At 18 years. But, in interacting with these facilities, we've seen healthcare workers bring pregnant ladies who were younger to us with their mothers. We have, a 14-year-old sweet young girl who, who is 8 months pregnant now, who we're supporting. We've seen, 17-year-old pregnancies. And so, based on the interest and the referral, we work with both the mothers and this young ladies in supporting them as well.
Thank you. A follow-up question to that is whether you think that your sample of 639 women was representative of the women of reproductive age in the country.
Okay, so let me take that as well. So we have a lot of young people on the platform, but we also have, but we have an age, like the age range, goes from, like I said, 14 all the way up to 48. We have older women on the Complete Health platform, but they are not grouped under this, the reproductive age. They're grouped under senior citizens who are living with, chronic diseases on the MDOC Complete Health platform. In terms of, we also looked at social demographics, such as, the schooling, the income range, and we saw that, yes, most of the women are low income women, but we also have, the sprinkles of women in other social, economic, other income classes as well. So I think we have a fair representation of women.
Thank you.
Yes, and Dr. Kendra, just to add to that, we also deliberately sampled a cross-section of women that were not pregnant, that pre-pregnant, pregnant, and then also post-pregnant, so that we could get a mixture from the population as well, adding to what the criteria that Kendra has already talked about.
Thank you for this precision, Dr. Okoli. A very important part of the discussion in the chat is about equity and how the original setting of this pilot is really in Lagos and the FCT, and how does it translate to rural women? Is that relevant for rural women, and are they going to be part of this intervention at some point?
Sorry, can you repeat your question, Benny?
Sorry, this question about equity and how the pilot of this project was very much in an urban setting in Lagos and the FCT. What does this mean for rural women? Are they going to be included in the intervention? And is this relevant for women who are not in urban settings?
Okay, so I can just jump in there, and I'm sure Dr. Koli can build on that. So in the selection, we're very intentional when working with the government in the selection of the local government areas. So like for those who are conversant with Lagos, we're working in Alimosho and Ikorodu, and they're very, very rural areas, within those local governments. Same thing with Abuja. One of the local governments was, the urban setting, and one was also the semi-urban setting towards the outskirts of the city. And so that allowed us to work with both women within the rural setting and the urban setting. Like I said, we have a lot of women, in that rural setting with basic phones, low level of education, and we were able to still support them using SMS and voice. And in some instances, even those, those who don't speak English, and we're able to work with them using interpreters or the MDOC health coaches that understood the language.
Just to add to that, I think I tried to answer that question on the chat box. When people hear about Lagos, they just think about Ikoyi. If you know Lagos well, Ikoyi, Lekki, and the rest of them. But, Lagos has a lot of urban slums. It's an urban area, but it has a lot of urban slums. And that's where we're, around the Ikorodu area, which is the local government that we're working, and a bit of Alimosho. The same thing with FCT. The Buhari area we're working has a lot of IDP camps as well. So in addition to what Dr. Kendra has already said. Thank you.
Thank you. When you presented the kind of tools you had available for women, you said yourself that not everybody has access to the technology. So there's a few questions there on how is this, does this reflect the kind of women who have access to the technology? What lesson do you have how to adapt this to reflect phone access and health literacy across the country?
Okay, so we saw, what we clearly saw was that smartphone penetration did not equal digital literacy. So even for those who had the smartphone, they had very limited use of that smartphone. So it was either the call, the voice message, and at best WhatsApp, which is very common in the African setting. And so whether with or without smartphone, there was that intentionality of building the skills. So we taught people how to download, we taught people how to bookmark the Complete Health platform to their phones so they could easily access it. We taught them how to join Zoom by doing demos with them, by sending screenshots, by meeting them in the facility during their antenatal sessions to teach them the basics of using their phone for health. I don't know, is there a follow-up question to that, or does that answer?
And Dr. Okoli answered that, but maybe you can say more about this for the internet connection and whether there was no compensation for women to connect to internet, and you discussed alternative, Dr. Okoli, on the chat.
Dr. Kendra, you can talk about the compensation to the women, but what I said on the chat is that not every woman had a smartphone, even though majority did, and we've heard what Dr. Kendra just said now. So for those that didn't, where the Complete Health platform connected them with SMS messages and telephone calls, and they were also able to call in themselves.
Yes, and so the women joined with their own data. We had that interest level. And for those who either did not have data or did not have smartphones, we still took the highlights following each session. We still sent over SMS messages and over the Complete Health chat groups, the key messages from the session, so that nobody was left behind in terms of knowledge gain.
Thank you very much. We saw then a few questions about specifically about COVID, and if you had a chance to look at the chat about the work about the ANC booking status at the site, knowing that this intervention started over a year ago, and there were questions also, very practical question on the implementation of the project. So people have all kind of question on, for example, the coaches, how many facilities they work in, how did you identify the coach, and what kind of additional workload did that bring for the health worker?
Okay, so I think I need to differentiate. We had different types of coaches, just like we had, the consortium of partners. So JPIGO had quality improvement coaches who were working with the healthcare workers on improving their quality of care. And on the digital side, we had the MDoc health coaches who were working with the women on providing, self-care management and, education on lifestyle modifications. So those were two different types of coaches working for two populations, but always providing that integrated approach in the way we linked the care. So the health coaches on the digital platform were always interfacing with the quality improvement coaches and the healthcare workers in the facility. The healthcare coaches, the healthcare coaches on the MDoc platform were people, and the first thing we looked out for were people who had empathy, towards in provision of care. And also they had to have a clinical background to be able to understand what the women were saying and to make sure that they were sound in self-care management as well as clinical care, to know, oh, this is an emergency, this woman needs to go to the hospital, and linking that. And I would leave Dr. Okoli talk about the qualifications of the quality improvement coaches that worked with the healthcare workers.
Okay, so we had two quality improvement coaches, one in Lagos, one in FCT. They were basically midwives and the midwife and the nurse. So one in each state, working with 10 facilities. The main work with the healthcare workers at the facilities, because we have to make this sustainable. So our goal is to ensure that the healthcare workers are working smarter and they are doing what they are supposed to do to improve quality of care. Of course, initially they will complain that there's a lot of workload, but what we are requiring them to do is to ensure that at least every woman booked in ANC has their blood pressure measured at every attendance, and at least first booking that women have their blood pressure measured, their weight measured, their BMI, diabetes screened, and also anemia. So at least these were what we were imparting to the healthcare workers, and they've been doing well. Unfortunately, if we present the whole project here, it will take probably more than an hour. So there are different aspects of the project. So the key thing is sustainability by the healthcare workers within the health facilities. Thank you.
Thank you. More on the implementation of the project. What is the lifespan of the project? And a follow-up question to that, what is the plan for scale-up?
I'll leave that with Dr. Okoli.
Thank you, Dr. I'm sure we have our founder on the line as well. So yes, so the pilot just finished this October. And we are lucky that the MSD for Mothers, they are happy with what we are doing, and they have kindly approved a scale up for another 2 years. But during that scale up, our focus is sustainability. So how does the states actually take this forward when we leave? We're going to scale up to another additional 10 facilities in each of those states. Like I said earlier on, we believe in leadership. So the states will actually help select the facilities where they want us to work, because they would have to sustain this project when we leave. Thank you.
One participant is wondering about the HR size of this intervention, and in particular, the size of the technical group to support the pregnant woman. How many people did you have involved in this?
So as our number, so like I said, as our number increased, we had to be very intentional about increasing the use of artificial intelligence, machine learning, automation, to make sure that we could provide this support to women at scale. And so we have an algorithm that stratifies the women into risk levels. And so the coaches, the in-person care from the coaches over the digital platform is provided to the high risk. And we have automated nudges and automated education materials that goes out daily to the women, and we're incorporating machine learning into answering the questions that takes away the HR weight of the program, so that it can really be automated and put to scale.
You mentioned in your previous answer sustainability, and we have a question from Dr. Adeniran on the motivation from the specialist team, because the health facility are given stipends for that. So how are you going to be able to sustain this?
Sorry, can you please repeat that?
So a question of sustainability, if the health facility were given stipends for this work, how is that going to affect the sustainability of the project?
Okay, I'll leave Dr. Okoli to answer that, but I know that for the teleecho sessions, we just gave stipends, data stipends for joining the call. And I'll leave Dr. Okoli to answer the rest of the question.
Okay, I didn't get the question right, but if it's in terms of what we paid to the health facilities, we didn't pay anything. The on-site capacity building was actually on-site. So, we just provided them with lunch, and they were willing to learn. That's one of the lessons we've learned here. The healthcare are willing to actually log onto that echo. It's like every other Thursday, people are like looking forward to logging and learning from that echo sessions, and then also learning from the on-site training sessions.
Let me just also build on that, because the RICOM 3 facilities are only 20 in number, 10 in each of the 2 states, and they are the only ones that we provide, a stipend to one person in the facility to take the call as a group. But we noticed that we were still having over 5 people join per facility during the COVID pandemic on their own data, where they couldn't come together as a group. We've also seen over 50 facilities use their own data to join the echo sessions. So this project, the one beautiful thing about this project is it hasn't been incentive driven at all.
Thank you. That's very interesting to know. I will take 2 more questions. One is on the cost implication of this intervention. If any organization would like to adopt this model, what would you say the cost implication is?
So what we haven't really talked about here is that we actually also had another arm of the project where we did the Health Strategy Delivery Foundation helped us to do a cost analysis of what normally obtains in the health facilities in terms of screening for all these indirect causes, and then compared it with the new women-centered quality of care model, which had additional things like the on-site capacity building, the ensuring screening of every woman, and then also the learning agenda, and also the virtual health support. And actually the cost difference is very minimal. There is not a lot of difference between the two, the traditional and all that. It's about being actually efficient in terms of the care that is being provided. So the Health Strategy Delivery Foundation has also done a study also looking at where can the states actually leverage funds from to actually sustain this project if they are going forward. And the states are very aware of this. They've given a number of avenues where they can actually obtain fundings or look for funding as they move on. But there is minimal difference between the traditional and the quality of care model, because we're using the same healthcare workers. It's just them being more efficient in what they're doing.
And that is a perfect intro to my last question about staff change and turnover. Is that a problem you faced, and how did you face this challenge if you did?
Okay, I was just actually responding to that. That was from Debbie Ambooster, yes. So it is a very major challenge for us, you know, especially I know two general hospitals, one in Lagos and one in FCT, where we've had huge staff turnover. So especially in the ANC division where we actually have worked longer. So what we do is, you know, we just constantly work with the MD of the general hospital and also the lead for quality improvement to ensure that any new staff that comes in, you know, they are helping to actually orientate them and, you know, so that they caught on to what they are supposed to be doing with the quality improvement teams. Our coach as well, that's where they come in as well. And of course, we have to just keep doing advocacy to the MD and the Ministry of Health to, you know, reduce the amount of movement of the healthcare workers.
Thank you so much to both our speakers today, and Dr. Okoli and Dr. Joku, and to this audience of participants who had lots of questions for you. To continue the discussion, I will direct you to our community of practice. You can see the link, the Join COP link, where we're going to pose this question and answer, and also the few ones that we didn't have the time to address today. You can see more about this series on the link that you can see on my screen right now, and register for the next event. The next lesson is going to be on adaptation and innovation for quality improvement teams, with example from India and Bangladesh on the 3rd of December. And you can also go on our website for more information about all our webinar series. I will, as I said, make sure that you receive a link by tomorrow with this recording, as well as the presentation that you saw today. And I look forward to meet you for the next webinar in December. Thank you very much.